When we look at tropical pulmonary syndromes, I even needed to understand what this topic is, because in tropical medicine, there are very many conditions that would affect the lung. And I think maybe that's what Dr. Mecha intended me to cover. Some of the conditions where you might have parasites specifically in the lungs, but also some conditions that are unique to the tropics that mainly affect the lungs. Some of these conditions, we don't have them in Kenya. You may see them if you travel or if you work in a setting where you have people coming from different parts of the world. And I think when I revise this lecture, maybe I would highlight certain endemic area, because there are certain diseases that are confined to different parts of the world that you probably maybe need to be aware of them, because I don't know where you'll practice. Many of you might want to practice outside of Kenya, and you might see some of these patients in emergency departments, for example. So for this particular lecture, I focus more on tropical pulmonary xenophilia, which is a fairly, I think is an under-recognized condition, but it's a favorite topic in our tropical medicine training, in tropical medicine exams. The only thing is, for those of us who live here, we probably have a low index of suspicion and maybe would still remain under-diagnosed or unrecognized. And as we go through the lecture, I'll highlight some of the important things to note. Another thing to say while I'm still at this initial slide is really to emphasize that a lot of the conditions that you've been, like the lectures have been planned under the tropical medicine and infectious disease series, you definitely mention the lung. If you're talking about the intestinal nematodes, they have a migratory phase through the lungs. If you're talking about schistosomiasis, there is a migratory phase through the lung. If you're talking about things like hookworm and strongyloides that penetrate the skin, there's a migratory phase through the lung. So again, conditions like low flash syndrome are very, very important. And I have not highlighted them in my presentation, but as I revise this presentation, and probably maybe we would have maybe a few minutes to take you through, we'll organize with Khan. And also importantly is that even as you continue to have the lectures, just pay attention, because your lecture, as we mentioned, a phase of migration through the lungs. So this is the intended spectrum of the lecture. Just looking at spectrum of tropical lung disease, just one or two slides. The Loeffler syndrome, I've put it here, but I've not yet added the slides. And once I revise the slides, I'll just need maybe about 15 minutes just to tell us what this is and how you suspect it and how long it lasts and how do you manage, or do you even need to manage it in the first place. So for the purpose of the lecture, my lecture focuses more on tropical pulmonary eosinophilia. But I put this slide here just to bring into focus what is the spectrum of what you call tropical lung disease. So we have nematodes that give you lung manifestations. So we have the ascariasis due to Ascaris lumbricoides, and we have ancylostomiasis, Ancylostoma duodenale, Necata americanus, and then strongyloides, and then Wucherera bancrofti, which is really the focus of our lecture today. So when we're talking of even pulmonary ascariasis, it's the larval forms that are migrating through the lungs. So we're not really saying that the adult forms will be found in the lungs, but it's the larval forms that migrate through the lungs and would manifest as these three diseases would manifest with the Loeffler syndrome. Can you hear me?
Yeah.
Okay. Then we have trematodes. Trematodes are the flatworms. So schistosomiasis and paragonimus, again, would have manifestations in the lungs. And particularly for paragonimus, where we have Paragonimus westermani and Paragonimus pacificus. This one, Paragonimus is a trematode that lives in the lungs. So that one, the pathology would be specific in the lungs and manifests with symptoms suggestive of TB, where someone has a chronic cough, they have pulmonary infiltrates, they cough out, in some cases they can cough out blood, and therefore the parasite lives in the lung. as opposed to schistosomiasis, where there's just a migratory phase through the lungs during the maturation phase before settling in the portal circulation. So they migrate through the lungs, penetrate, ascend the airway, and then are coughed, and then swallowed, and then now they go to their final destination. So just to highlight the difference. And then for the cestodes, I will be taking you through cestodes this afternoon. So I don't want to preempt what my lecture is, but particularly for Echinococcus granulosus, which is common in our setting, not really common, but it is found within our setting as opposed to Echinococcus multilocularis. This one, you can have the cyst within the lungs. So we'll talk more about this in the afternoon. And then there are some protozoal diseases still that affect the lungs. So things like amoebiasis, leishmaniasis, and even malaria. We already had our lecture of malaria, and we know that malaria can present as a severe and complicated malaria, presenting with acute respiratory distress syndrome, where there's involvement of the lungs. For amoebiasis, again, you can have the amoebic cyst can be found within the lungs, and this is where you might even find the patient is coughing what is called the anchovy sauce because of a ruptured amoebic cyst. So you can have the cyst within the lungs. You can have Leishmania donovani within the lungs, particularly in patients who have immunosuppression, where they have maturation of the Leishmania outside of the normal reticuloendothelial system. So you have maturation in places like the lower esophagus and the viscera. So you can have pulmonary manifestation. And then pulmonary toxoplasmosis and Babesia. We don't talk so much about Babesia. This is a tick-borne infection caused by Babesia microti that would present and mimic malaria, would present with an acute febrile illness and mimics malaria. It's actually found intracellular within the red blood cells. It's not found in our jurisdiction, but it's found, it's a zoonotic infection, more found within North America. So we'll not talk so much about Babesia, but it causes disease also in livestock. So we go straight on to tropical pulmonary xenophilia, and you might have mentioned this in your microbiology lectures in second year. So TPE is a result of hypersensitivity reaction to microfilaria of Wuchereria, Bancrofti, and Brugia malai, which are trapped in the pulmonary microcirculation. So remember, Wuchereria and Brugia, they are lymphatic filariasis, but the microfilaria that are produced are found in the blood. So when the blood is circulating, the microfilaria would be trapped in the pulmonary circulation, and therefore a proportion of people may develop hypersensitivity reaction to these microfilaria antigens within the pulmonary system, and therefore they present with a chronic presentation. It was first described in 1943 in India by Wayne Gatton in patients with suspected TB who had what was called spasmodic or episodic bronchitis. They were found to have eosinophilia, and on the chest radiograph, they were found to have fine spotting on the chest radiograph. And therefore, thereafter, after investigation, they coined this and they said it was tropical pulmonary eosinophilia. So it's unique to the lymphatic filariasis, specifically Wuchereria and Brugia malai. This is just to remind us of the life cycle for the two organisms. So it's spread by mosquitoes. The microfilaria are transmitted by mosquitoes, and the mosquito take a blood meal, and during the blood meal, the L3 larvae are ingested into the skin, and then they move from the skin, and then you have progressing on and maturing into the adult forms in the lymphatic, and you have two adult forms, the male and the female. So they are sheath microfilaria. They migrate into the lymphatic and blood channels. And although the adults are found in the lymphatic system, they produce microfilaria that are circulate within the blood. So when they are when the mosquito is taking a blood meal, then it's able to pick the microfilaria, which again have a cycle within the mosquito. So in the mosquito, the microfilaria shed the sheaths, penetrate mosquito midguard, migrate to thoracic muscle, and then they mature from L1 to L2 and then L3 larvae. And then the L3 larvae migrate to the mosquito head, where in preparation for the blood meal, so that they can be ready to be released during the next blood meal when the mosquito is taking the blood meal. And the same would be similar for Brugia, Malaria. They have a similar cycle because they are both causes of lymphatic filariasis. So TPE occurs in less than 1% of patients with lymphatic filariasis, and it's predominantly a male disease. So the male to female ratio is 4:1. It primarily affects the lungs. Approximately 7% of the patients show extrapulmonary and extralymphatic manifestations. We'll talk about this, mainly hepatomegaly and splenomegaly, but it primarily affects the lung. So in terms of the natural history, when you look at the pulmonary pathology, the findings include acute eosinophilic infiltration in the form of eosinophilic bronchopneumonia. So basically what this means is the presence of the trapped microfilariae and the microfilariae antigens stimulates migration of eosinophils, and the lung is infiltrated by a lot of eosinophil, and that's why they get this eosinophilic bronchopneumonia. In some cases, you can have eosinophilic abscesses or collections of infiltrate, or a mixed cellular infiltrate where you have eosinophils and histiocytes, and this appears 6 to 2 years after the infection by the Wuchereria or Brugia infection. In some chronic cases, you can have development of interstitial, peribronchial, and perivascular fibrosis. So you have fibrosis due to infiltration of histiocytes, and this can complicate then with pulmonary hypertension and the consequences that happens thereafter. In terms of clinical presentation, the symptoms are non-specific. So you'll not find one unique symptom to tell you that this patient has TPE, but based on the exposure, epidemiology, and presentation, you might have a higher index of suspicion. So the patient presents with fever, they have weight loss, they have malaria, and then they present with predominant nocturnal respiratory symptoms such as dry cough, dyspnea, wheeze, and chest pain, which occur mainly nocturnally or at night. So if someone has this presentation, you have to suspect. But remember, again, things like asthma have a predisposition for nocturnal manifestation when the air is very cold. So it may be one of the things you would suspect your patient. But if, for example, the patient is not known to be asthmatic and then they have this acute manifestation and they are traveled to an area where they might have been exposed to infection with Wuchereria or Brugia, then you have to suspect that they could have developed TPE. Sputum is usually absent. Remember, it's a dry cough, but when it's present, it's viscous, mucoid, and if you were to look at the sputum microscopy, you'd find significant eosinophil within the sputum. Examination really doesn't reveal much. There'd be scattered rhonchi and rales, but you may pick extrapulmonary manifestations in other systems. So the reticuloendothelial system. So there may be lymphadenopathy as well as hepatosplenomegaly. One of the outstanding things is if you look at the blood for the patient, there'd be leukocytosis in the peripheral blood with a predominance of eosinophils that can be as high as 50,000 to 80,000 cells per microliter. So there's an eosinophilia. So there's pulmonary eosinophilia, as well as even peripheral eosinophilia as well. So in terms of differential diagnosis, some things that you need to think about, even when you're thinking your patient could be having TPE, would include non-infectious causes of eosinophilia that include drug hypersensitivity, asthma, allergic rhinitis, allergic bronchopulmonary aspergillosis, and acute eosinophilic leukemia, as well as myeloproliferative disorder. So these are conditions that are not infectious in nature, that are caused by, that manifest with elevated levels of eosinophils in the body. So a lot of the drug hypersensitivity reactions would be marked with eosinophilia. The same with asthma, the allergic rhinitis, and the entire list. Acute eosinophilic leukemia is an acute leukemia where the eosinophils are the predominant cells. So in such a patient, when you find the eosinophil count is elevated, and some of the conditions again would affect the lungs, then you have to think and rule out some of these conditions, because they can share clinical findings as well as even presence of eosinophils peripherally as well as in the blood and in the lungs. In terms of your laboratory evaluation in these patients with tropical pulmonary xenophilia, you will not see microfilariae in the peripheral blood. Remember, it's a hypersensitivity reaction, so you may not necessarily see the microfilaria in the peripheral blood. And this microfilaria could have been trapped in the lungs way back when, and the symptoms still continue the patient continues to have the symptoms even at the time when they don't have circulating microfilaria. The ESR is elevated in most cases. It, however, returns to normal after treatment. The serum IgE and IgG levels are elevated with significant reduction, but not total normalization after treatment. So when you're even doing your assessments or assays for IgE and IgG antibodies, you have to remember that there's cross-reactivity with other helminths, such as Ascaris and Strongy, that can still give you Loeffler syndrome. And in some patients, as high as 20% of the patients, you can have co-infection, where someone has been infected by Strongyloides or Ascaris, and at the same time, they also have been infected by Brugia malaria. So you have to keep that at the back of your mind, even when you're sending for the assays. Some patients may show arterial hypoxemia. So if you do the blood gas levels, there is hypoxemia. And this is probably due to ventilation perfusion mismatch at that point in time when they have the TPE. Advanced cases of TPE present with signs of pulmonary hypertension because of restrictive ventilatory defect. So chronic pulmonary hypoventilation then leads to pulmonary hypertension, as well as continued embolization of the dead microfilaria in the lung capillary. So this may be a long-term complication of TPE, where the patient, at the time when you're reviewing them, may already have pulmonary arterial hypertension. You may have some cardiovascular manifestations that may be present, such as electrocardiographic abnormalities, consistent with, for example, in patients who have pulmonary arterial hypertension. Some patients may have pericarditis, and some patients even may have pericardial effusions. So in terms of diagnosis, I think the first thing you have to do is to differentiate TPE from other parasitic helminth infections that present with eosinophilia and pulmonary symptoms. And this include all the helminths that either live in the lung or migrate through the lung. So you have the Strongy, Ascaris, Paragoniasis, and Xylostomiasis, which is hookworm infection. Toxocariasis. Toxocara is it's an intestinal nematode for dogs and cats that can affect humans if you get it's transmitted fecal-orally. So if you ingest the eggs for Toxocara, you'll get what is called visceral larval migrants. They migrate within the viscera, but because you're not the definitive host, they'll keep on migrating throughout the viscera without maturing. So it's one of the causes of eosinophilia and visceral larval migrants. Schistosomiasis, we already know what that is. And then other gastrointestinal helminthic infections. So in your patient, you have to suspect these other conditions that can present with eosinophilia in the presence of pulmonary symptoms. And this presentation is more of Loeffler syndrome, which is transient and is not really TPE. The other, so in terms of the current diagnostic criteria for TPE, there's a criteria of these 7 aspects that you have to consider. So the first one is history, supportive of exposure to lymphatic filariasis in an endemic area. So this could be someone who either lives in that endemic area and could have been exposed because of living in that endemic area, being bitten by the mosquitoes. And then the other thing you have to remember is if someone travels to the endemic area and stays there over a significant duration of time, they may still be infected. And even when they travel back away from that endemic area, they might develop symptoms consistent with tropical pulmonary xenophilia. So you don't have to stay in that area for the entire time. So long as you've already been infected, you then stand a risk of getting TPE. The other important criteria is nocturnal, cough, and dyspnea. And then pulmonary infiltrates in chest X-ray. So you have to do a chest radiograph or imaging to be able to pick the pulmonary infiltrates. And then when you look at the blood, you have elevated peripheral blood eosinophils, more than 3 times 10 to the power 9 cells per microliter. So normally when the eosinophils are more than 500 cells per microliter, then that's significant. You start saying that patient has eosinophils. And then elevated serum IgE levels, more than 1,000 kilounits per liter. And then increased titers of filarial specific antigen in the serum. So immunoglobulins in the serum. So IgG, isoenzyme, like isotype G1, G4, IgE antibodies, and then clinical response to DEC. So if your patient has the first 6 criteria and you start them on diethylcarbamazine and they respond, then you conclude and say you've actually confirmed a diagnosis of TPE. So when you're looking at this diagnostic criteria, these are the important things that we need to do for the patients as part of their workup to say that they actually have TPE, or what is the history or the information that we need to take. So the history of being exposed in an endemic area, the symptomatology of cough and dyspnea, the infiltrates on chest radiograph, and then elevated eosinophils, elevated serum IgE levels, and then increased titers of those specific immunoglobulins in the serum, IgG and IgE, and then increased response to DEC. There are these other additional tests that are not really available widely for clinical use. So this ELISA test, OG4C3 and BMSXP1 antigen ELISA test, has been developed that's able to look at to detect the Wuchereria bancrofti and Brugia malaria infections respectively. So the OG4C3 is for Wuchereria and BMSXP1 is for Brugia, but they're not available really for clinical, like for day-to-day diagnosis of patients. They are still fairly new. Naomi. Then you have the RT-PCR assay that is, again, more for research, that's able to detect the presence of the parasites. So this is just a compilation of different images. And you can see in the first radiograph, we have infiltrates, and in this particular patient, the infiltrates are more peripheral, more peripherally distributed. Then we have the CT scan, and we can have, we see the areas which are highlighting around the airways. So the peribronchial cuffing that we talked about. On the lower quadrant to the left, we actually see, so in that image, you can see the clear areas. Those are the air spaces. But what is of note is the areas that are highlighting pink, like where my pointer is and where the pointer is. And those are actually like eosinophilic abscesses, where you have collections of eosinophils that are clumped together. So normally, in a normal lung, you don't have a lot of eosinophils. Eosinophils are cells that stain red. If you're using your traditional GM stains or H&E stain, so they stain reddish because of the granules that they have in the cytoplasm. And then on a closer look, we can actually see the reddish staining cells that are very markedly distributed within the lung. So that's what you're talking about, eosinophilic infiltrates within the lungs, which is one of the diagnostic criteria that you need to do if you're able to do the biopsy. So in terms of imaging or pulmonary imaging, you may do a chest radiograph, or you can even do a CT scan of the chest. So in the chest radiograph, you can have different findings, but the most common radiological finding is bilateral fine diffuse reticulonodular opacities in the middle and lower lung zones. Some patients may show fine mottling similar to the radiological findings of miliary TB. 20% of patients have normal chest radiograph. So you may do the X-ray and still find that it's normal in about 1/5 of the patients. In advanced disease, patients may have honeycomb changes that are typical of pulmonary fibrosis. You may have other unusual findings like consolidation, lung masses, cavitation, hydroneuromothorax, and pleural effusion. So you can have very different radiological findings. But so long as you have some infiltrates in a patient who has exposure and the clinical criteria that we've already talked about, then you can suspect that you're dealing with TPE. Chest CT scan of the chest may show reticulonodular pulmonary opacities, bronchiectasis, air trapping, and mediastinal lymphadenopathy. So when you treat your patient, not all the radiological findings disappear, and it's not in all the patients. So up to 40% of patients may still have radiographic abnormalities even after 1 month of treatment. So even despite treatment, the radiological changes may not totally be reversed to prior to the infection. So that's one of the things to remember, so that in such a patient, even you cannot use that criteria then to say that the patient, even like the patient might show clinical response, but the radiological findings might persist. So you use the clinical criteria to say the patient has responded to DEC. The nocturnal cough would disappear and the dyspnea would improve. In terms of your pulmonary function test, in early TPE, you'd have a mild to moderate obstructive ventilatory pattern that is commonly seen. However, in more advanced cases, your pulmonary function tests usually show a restrictive pattern because of the fibrosis. There is restriction of lung expansion. So in approximately 30% of the patients, you might have a superimposed irreversible obstructive ventilatory defect that can be found in those patients. So there is no reversibility, even when you try to do, normally when you do the pulmonary function test, you first want to assess what type of pattern is it. And then in patients who have an obstructive pattern, you want to see if that obstruction can be relieved by bronchodilators like salbutamol. So in most cases, you can have, in patients with TPE, that the obstruction is not reversible. So even when you give them the salbutamol and wait over a certain time and repeat the pulmonary function test, there's no reversibility. Reversibility is one of the criteria that helps us to diagnose conditions like asthma, which are part of the reversible airway obstructive disease. Some persisting abnormalities in patients who are treated with DEC may include decreased FEV and reduction in the diffusion factor, the single breath transfer factor. And this may be due to reduced diffusion capacity for carbon monoxide through the reduction of the number of alveoli. So when you're doing the diffusion factor, it's basically looking at the integrity of the membrane, the thin membrane between the alveolus and the endothelium, the capillary endothelium. So in some cases, when you have long-standing fibrosis, the diffusion factor or the transfer factor would be reduced because now there's thickening of that membrane that impairs lung, oxygen diffusion across the membrane. So that is one of the characteristics that may explain in patients who have persistent sort of like non-response, even despite treatment with DEC. Other parameters such as the peak expiratory flow rate and forced expiratory flow, which are diminished in patients with untreated TPE, can continue to be diminished even after DEC treatment. So not all the patients who are treated necessarily show clinical response. Some patients might have persisting residual effect, and we'll talk about what to do for some of these patients when they don't respond to your initial treatment with DEC. So your treatment of choice for patients who you've made a diagnosis of TPE is to give them DEC, which is diethyl carbamazine. And it has a long name that you can see there. We just know it as DEC. This has been used since 1947 to treat filariasis and to continue treating TPE once TPE was diagnosed. So in terms of the things that DEC is able to do, the treatment has been shown to reduce the eosinophil lung and blood count. So the levels of eosinophils in the blood and in the lungs are reduced. It's able to also reduce the titers of specific antifilarial antigens, particularly IgE and IgG for the antibodies, not antigens, to reduce the antifilarial antibodies, IgE and IgG type 4. It's able to directly suppress interleukin-5 dependent eosinophilopoiesis by the inert nitrous oxide and through this other mechanism. So it's basically able to suppress production of eosinophils. Remember, in this condition, we have eosinophils that are circulating in the blood, some in the lungs. So by reducing the total amount of eosinophil through the use of DEC, you're able to achieve that response of reduction in the quantity. DEC also has direct microfilarial activity, both in vitro as well as in vivo. It's also able to interfere with arachidonic acid metabolism, including both the cyclooxygenase and lipooxygenase pathways. So it's an anti-inflammatory mechanisms in both microfilaria and the host endothelial cell. So it's able to mediate the anti-inflammatory response. So it works through all these mechanisms. And remember, in the clinical criteria, we had a lot of these things, that there were a lot of eosinophils in the blood as well as in the lungs. We had high circulating levels of IgG and IgE. We had a lot of total number of eosinophils in the blood. So by interfering with all these direct different pathways, DEC is therefore effective for treatment of TPE. And the dose that is recommended is a dose of 6 milligrams per kg, divided into 3 daily doses. And this is given for a period of 21 days. And the characteristic expectation, patients respond very rapidly to DEC treatment. Majority of the patients respond fairly when you introduce TPE, when you use DEC for their treatment. However, we have a high proportion of patients who will fail, about 20 to 40% would fail to respond to DEC. And some of the causes could include incomplete treatment, either inadequate dose or shorter duration, or patients who have advanced disease with pulmonary hypertension, very advanced fibrosis or long-standing disease. Persistent airway inflammation and diminished lung function, despite, and the patients who have DEC failure, how you are able to identify them is because they have persistent airway inflammation and diminished lung function despite receiving standard DEC treatment. And in this group of patients, there's been a role for use of corticosteroids with caution. So the caution here is that we know that corticosteroids can induce strongyloides hyperinfection. So you really have to be cautious that your patients are not co-infected with strongyloides before giving them the steroids, because then in such a case, you might actually precipitate a strongyloides hyperinfection. So you need to screen for strongy, maybe give a dose of ivermectin to treat the strongy before you introduce the use of corticosteroids for these patients. Some side effects for DEC include headache, fever, GI manifestations. However, the use of DEC is contraindicated in patients who have onchocerciasis, and I'm sure this has been emphasized over and over when you have your lectures on onchocerciasis, or even when you have your lectures on systemic lymphatic filariasis. And this is because of what is called the Mazzotti reaction, which is an intense systemic reaction manifested by hypotension, pruritus, fever, enlarged lymph nodes due to death of the circulating microfilaria. So the microfilaria, you don't use DEC in patients who have onchocerciasis. DEC again should also be carefully administered in patients who have lower high levels of lower circulating. And this is because of potential of life-threatening effects that include renal failure and meningoencephalopathy, as well as even eye damage because of the high levels of microfilaria, lower that might be killed, and it induces an inflammatory response. So you really have to screen your patients for these other parasites, the onchocerciasis, as well as lower lung, which are tissue filaria that are found in the subcutaneous tissue. So this was a short lecture. I think this is my last slide. And just to conclude that TP is an occult form of filariasis, which is the result of a hypersensitivity reaction to trapped microfilaria or the antigenic products of Wuchereria bancrofti and Brugia present in the pulmonary microcirculation. It affects mainly young males. It affects initially the lung airways and is characterized by development of eosinophilic alveolitis. The standard treatment is DEC, and we've talked about in patients who are non-responsive or have treatment failure, the alternative treatment and the precautions you need to take for those group of patients. And then we need better diagnostics and pharmacological drugs to minimize the morbidity and to also avoid the development of interstitial pulmonary fibrosis. So this is my last slide. I'll stop sharing and then respond to the questions so that can all go for the lunch break. Oh, so Christine is asking, there's someone who I didn't understand that question, maybe they're still typing. Christine has asked, how do corticosteroids induce strongyloides infection? So corticosteroids, basically they're anti-inflammatory. So in patients who have strongyloides infection, the parasites lay the eggs, and the eggs hatch within the intestine. And strongyloides is one of those infections where you have auto-infection. The strongy doesn't have to come out, the larval forms don't have to come out of the body to mature in the soil before they become infective again. You have the L3 larvae, the L1, L2, L3 larvae, they mature within the intestine, and you have what is called auto-infection, where it's able to penetrate the intestinal skin. So there are certain conditions where you can have what is called hyperinfection, where you have extremely large amounts of parasites that multiply and infect the individual. So in patients who have corticosteroid, who are on corticosteroid therapy, patients who are on other immunosuppressive therapy, patients who have HTLV-1 infections, those are conditions that have been shown to predispose to hyperinfection. So in patients who have hyperinfection syndrome, they have overwhelming penetration of the larval forms through the GI. And as a result of that, there is penetration, following the penetration, there is also introduction of the gram-negative enterobacteriaceae into the bloodstream. So the patients would actually develop gram-negative septicemia. And because there's a large amount of parasites circulating through from the gut, through the liver, through the lungs, the patients are very, very sick. So it's one of those medical emergencies where you're likely to lose your patient to the gram-negative sepsis and the strongyloides hyperinfection. And in this group of patients, you need to treat them with ivermectin. And then you also have to give them broad spectrum gram-negative cover. In patients who have hyperinfection, they actually develop, they have the Loeffler syndrome. And when you look at their sputum, you'll actually be able to see the strongyloides rhabditiform larva in their sputum. So that's one of the ways of making the diagnosis. But you have to have a high index of suspicion because the patients are very, very sick. So when a patient who you haven't screened, and some of this, for those of you who are very curious to read, you'll be able to find case reports that are published in the West of people who maybe they were immigrants, they had been on a transplant list, then they received an organ transplant, even for a solid organ, so like a kidney transplant, maybe lung transplant, and then they developed gram-negative sepsis, and when they were evaluated, they were actually found to have strongyloides hyperinfection. And some of them, a lot of patients who develop hyperinfection actually die because the index of suspicion is low and time is lost before the patients are evaluated and treatment is initiated. So it's one of the things you need to remember. The corticosteroids are immunosuppressive, and they induce multiplication of the strongy, which then results in penetration and entry into the bloodstream of the strongy level, as well as the gram-negative bacteria that are found within the gut. So the patient gets gram-negative sepsis. So I don't see any other question, and we are meeting again at 4:30. So we'll end this session and reconvene again at 4:30. Is that okay?
Yeah, it's okay. Taimur has left temporarily to go and pray.
Okay, so you're in charge. That's Eugene.
Yeah.
Okay, so we'll end now. We'll meet again at 4:30. Have a good afternoon.
You too, Doc.
Bye-bye. Bye.
Recording stopped.